June 9th is our annual meeting. I'll let Elsa talk a little bit more about that. And then two other trainings that we have coming up are April 18th. That'll be about communication for the 45 to 49-year-olds. For colorectal cancer screening with Dr. Whitney Jones. That should be on your calendar. There is a registration link in that meeting invite, and then I'll send out the registration link as a reminder sometime next week. And then in early May, we'll have another training with the Patient Navigation and Community Health Worker Training Collaborative. And that'll be about digital health literacy training. So we'll send out more information about those two trainings coming up. And then Elsa will go into some detail about our upcoming annual meeting.
Hi, everyone. Thanks so much for joining our monthly call today. So as Wesley noted, we are going to be hosting an in-person annual meeting this year for the first time since before COVID. So really excited to have the opportunity to bring everyone back together. That one will be in person at the CU Anschutz campus on Friday, June 9th. Looking at 8:30 a.m. to 3 p.m. And CCSP will be able to cover travel, reimburse for travel for everyone coming outside of the Denver metro area. So for those just coming a little farther away for a day trip, can reimburse for mileage. For those that are coming from more of the western slope or eastern plains, we will be able to reimburse for overnight hotel stay as well as mileage. So really hoping we can have all of the current clinics participating in CCSP have 2 or 3 folks join us for our annual meeting, and we'll be talking about the wrap up of this grant cycle and weaving in components of the colorectal cancer, lung, and hereditary work, and then really starting to think about that implementation of the next grant cycle focused on colorectal cancer screening, EBIs. So we'll have more information, the registration and the travel details sent out soon, but please mark your calendars for June 9th and really hope we can see everyone in person.
Awesome. Thanks, Elsa. So now I'll hand it over to Doctors Ende and Shoemaker, and I'll let them introduce themselves and give a little overview of the program that they have.
Great. Thank you so much, Wesley. So I'm Alex Ende. I'm a gastroenterologist based in Denver. And then I'll let Nate introduce himself briefly, and then we'll talk to you about what we've been working on.
Yeah, Nate Shoemaker, also a gastroenterologist based in Denver, and Alex and I have kind of started, well, not just started, but a couple of years ago started this endeavor that we're going to talk to you a little bit more about, and give you a little more detail on what we're planning, what our vision is, what we intend to accomplish with this, how it can help improve rates of colon cancer screening and improve prevention in rural communities that are underserved. And then we really want to give a lot of chance for questions and discussion, and not just so that we can answer questions you have, but also so that we can come up with ideas based on those questions and where they lead us. So do feel free to jump in if anything comes up. I think we've got a lot of minds in here that could be helpful. So appreciate it. Great.
So I have a brief slide presentation, but as Nate said, we really want to kind of get a conversation going. So I'm going to share my screen here. All right. So we're calling our new kind of enterprise here GI Community Solutions. So what is that? This is something that started originally in 2020 when our regular practice was shut down during COVID. I started going to Goodland Regional Medical Center, doing GI care there, initially 1 day a month, and then have increased to 2 days a month just based on need. Nate has been going to Hugo, Colorado, to Lincoln Medical Center, and has we've both really kind of had the same experience. Most importantly, we find it incredibly gratifying. I think we both describe it as kind of the best part of our work week. And we've also just noticed an incredible demand, which I don't think will be a surprise for anybody on this call, that patients in rural areas just don't have the same access to care as patients, say, in Denver or Colorado Springs do. And just by kind of being available, we've seen an incredible number of patients come through with really complex GI conditions that we, have had the privilege of taking care of. So I'm going on 2.5 years now at Goodland, and Nate is actually at a year. And similarly, as we've identified more rural sites, we've actually had a lot of interest from our partners and other GI doctors in Denver to do something similar. So that really prompted us to kind of, make this a little bit more formal, and actually start an organization called GI Community Solutions to really pair the GI docs in Denver and the more rural sites around Eastern Colorado, Western Kansas. As you know, rural hospitals oftentimes don't have the same number of specialists. They oftentimes have primary care doctors, family doctors, but not usually the specialists, just because they don't have a need to have somebody based there full time. Patients oftentimes don't have the means to travel to a bigger city, or just don't want to. And that what we found in both these places is that endoscopy was already being done by primary care doctors and surgeons, but really the need was in complex diseases like inflammatory bowel disease, hepatology, any GI condition, but especially the more kind of complex conditions. There was not that expertise locally. So that's where we really kind of see our niche being. So the thought is that it's not a GI doctor who comes out like a typical locums model and does a weekend or fills a gap for a week. It's somebody that's regularly devoted to a site long term. Just like I've been going to Goodland, Nate's been going to Hugo. We want that one person going to that one site for perpetuity, 1 day a month, maybe 2 days a month. But the idea is that they establish contacts with the local providers so that everybody knows this is our GI doctor. And similarly, I think even more importantly, is that there's longitudinal care for the patients. If you're going to care for inflammatory bowel disease, you can't show up once and then disappear for 6 months. You've got to be the kind of regular person. If you're starting biologic agents, you've got to be available and coming back for those follow-ups. We do obviously do endoscopies as well. It's not, we don't have the ability to do every single GI procedures, but we're doing the bread and butter stuff. So we're doing upper endoscopies, we're doing colonoscopies. Obviously, these are all full-time gastroenterologists, so we all consider ourselves very competent endoscopists and able to do, really any kind of general GI procedure, and we think, do it very well. The longitudinal care here is really key, that we focus on the complex diseases. We don't limit patients to certain conditions, but I think this is where we can really have the most impact. And it is outpatient only. We're not set up to be able to cover hospitals and do inpatient consults or emergency procedures, because the model is really based on being there a day or two a month. I think another important thing to stress early on is that we know that GI care is also provided by surgeons and primary care doctors, obviously in the office, but also including endoscopy. And we do not view our role as coming in and doing every endoscopy. We view it as coming in to work alongside the surgeons and the primary care doctors. And I think we've really modeled in Goodland and Hugo so far that relationship works out really well for everybody. Being able to do endoscopies there generates more referrals for surgeons. Oftentimes primary care doctors are not comfortable doing certain procedures or more, complex polypectomies. We're happy to help out with that. But the idea is really that we work alongside the surgeons and the primary care doctors that are already based there. we've decided, after some kind of back and forth, we really decided to structure payment for this as a per diem model. And really what that means for everybody is that we are flexible in what the needs of the local sites are. So if the need is more for endoscopy, that's fine with us. If the need is more for office visits, that's fine with us. You know, we don't have to do a certain number of procedures to be profitable because that's just not how the model is set up. Similarly, we don't want to come in and start referring patients out of these local sites. We know that rural sites, you know, take a lot of pride and have expertise in taking care of their patients locally, and we want to keep it that way. So, you know, patients need referrals for surgery, for oncology, that's done locally. The idea is not that the patients end up going to Denver. Obviously, you know, most of the patients don't need those referrals, but when that comes up, you know, we like to keep them locally, and we tend to defer to the, you know, to the family medicine doctors and primary care doctors for referrals, because they have relationships there, you know, that may be ongoing and been in place for a long time.
Yeah, and there will be a lot of things that need to go to Denver. I mean, there are a lot of these communities that don't have oncology and don't have the ability at their hospital to do a colon resection for surgery. And when that's the case, I mean, while they take a lot of pride in being able to take care of their patients with what they have in their community, they also readily recognize there are situations where it needs to go elsewhere. But even with that one patient in every so many needs to go to Denver, all the other ones that we can take care of, routine outpatient endoscopy and colonoscopy, is all being done in the community. So I think that this, you know, with CCSP and some of the local alignments in Denver with university and elsewhere, is another strength of the model, in that, you know, I have a patient from Hugo who I literally just got off the phone with the colon peritoneal cancer multidisciplinary team, so that I can send the patient for surgery because he needs colon cancer resected. So there are a lot of winners in this model, pretty much everyone involved. And so, yeah, there's stuff that will need to go to Denver, but it's about minimizing that as best we can.
Yeah, that's a good point. Yeah, thanks for clarifying that, Nate. The other important part of our model is that the physicians, they're there for the day. So, you know, certain sites, if they're far away, they may need to come out the night before, but in general, we try to keep it where this is a daytime job. So when I go to Goodland, Goodland has a system set up where they fly all their specialists out from Centennial. So I leave in the morning, I'm back in the evening. Nate drives out to Hugo. And I think that really is kind of going to make it a lot more appealing to physicians from Denver, is that they're not needing to stay overnight. There may be some sites where that's just not possible, but, you know, for right now, when possible, that's our goal. The schedule is all managed by the primary site. As I said, you know, we work with the local sites to figure out what the need is, but in general, they build the schedule, whether that's procedures or office visits. We do have the goal eventually of making pro bono care a part of this. Right now, we're not doing that. We're just starting this off the ground, and, you know, our first step, I think, is to get more of the rural sites involved and get more physicians involved, so that we can grow that way. But our eventual goal is to have some more pro bono care, so that maybe each doctor does some time at either, again, office visits or procedures with a site in Denver, because we think that's an important part of the model. Just like we're trying to improve access for rural patients, I think improving access for, you know, for lower income patients in Denver is an important long-term goal of ours as well. And again, that could potentially mean partnership with larger healthcare entities in Denver. I think we're really kind of open, especially to, you know, to your thoughts on this. But we see that as a long-term goal for this. That's all I have. I just wanted to keep this really brief because we really want to hear from everybody on this call and get your thoughts about this. And please do not hesitate to contact us. These are our emails. You can, you know, even if it's just a thought, a suggestion, we're, eager to kind of get involved with this community and hear back from what you all think. So I'll stop there, but love to hear from everybody.
Thanks so much for that overview. We have a bunch of folks on, I see, from the San Luis Valley, the Arkansas Valley, over on the western slope as well, and then a little bit in the Front Range also. So I'd be curious to open up to the group, including those out in our rural areas, if you feel like there would be a need for additional capacity for endoscopy in your communities. Since we have been hearing a lot on our calls that things are still backed up and delayed and have just really high need since COVID. So I'd really love to open it up to the group for some of you on from our rural communities, and if what's coming up for you based on Nate and Alex's presentation.
I'll give a few seconds and then I'll jump in with something else that I can add on to it, but I think as we work through this, one of the best parts of the model and what we can offer these communities is not just the longitudinal continuity with patients in terms of outpatient care, but when you look at the classic, I mean, this would technically fall under the umbrella of locum tenens, right? Someone's doing a job that's outside of their primary practice. I think the basket from which you're selecting those physicians typically for a locum tenens position where they're going out to a community to cover their hospital for 2 weeks at a time, something like that. That's your classic locum tenens for a physician where they're spending a big chunk of time going out somewhere, covering that hospital, which implies that they're not in primary practice somewhere else because they have the time to go for 24 hours a day, 7 days a week to cover a hospital. We're really hoping to select these physicians from the Denver area because we know all of the young physicians in the Denver area. We know the qualifications of them. We know how capable they are. And so we're really getting out to these local communities, not just someone that can push a colonoscope and do the procedure technically, but these are like the best gastroenterologists in Denver. And that's the plan, is so that we're not only providing care and checking the box, but they're actually getting what I would say is better care than if you were to select a random GI practice from the Denver area, which comes as a huge, huge benefit to the local community, especially if we can establish that continuity long term. So it's not only that we save them the trip to Denver, but they actually get the best care from Denver without having to leave home.
So I'm not a decision maker, but I'm with High Plains Community Health Center in Lamar, Colorado. And we have Prowers Medical Center out here. We are losing our internal medicine, our surgeon for GI issues, and we're transitioning to someone else. So I will send this information on to my supervisor who can meet with PMC and give them some information, because everything is transitioning right now. As you've noticed, we're losing people left and right. So it would be nice to have at least a backup, somebody who can come in and help out our small community. We've got a lot of cancers here, and getting those screenings is vital.
Yeah, absolutely. I mean, I think that your community is no different than most out there, that they are losing the ability to do this. And as even though there are internal medicine physicians in rural communities that have been doing endoscopy and colonoscopy for a long time, primary care physicians trained now are not trained in this for the most part. Now, there are people that seek it out on their own, and are trained to do it. But for the most part, these are eventually going to be phased out, and there's going to be no primary care physician that can do this without a specialist of some sort. And luckily, general surgeons and so forth have been able to fill the need in a lot of these communities. But I think we've seen with the education to these populations and the access somewhat improved, that now they can't handle that capacity. And so there's going to be delays to care with that in terms of screening and prevention, because I think that is a signal of, that's a sign of success when you've got more patients coming in, that you're actually kind of exceeding your capacity to date. So they need help. I mean, there's backlogs in a lot of these communities, which is where we're seeing the need from a procedural side.
And I saw that Marisa from Valleywide put in the chat that it's definitely needed in the San Luis Valley. There's many transportation barriers, so definitely would be nice to have more timely specialty services without the travel barriers. Marisa or Laura or anyone else from the Valleywide team, is there anything else you'd want to add related to this if you want to come off mute?
This is Laura. And I know that our local hospital and other clinic that's not affiliated with Valleywide do have specialty providers that come in with regards to, say, cardiology or urology, and they do specialty clinics on a regular basis. Is this something that you or this program would possibly be able to provide us?
Yeah, that's exactly what we provide. I mean, it's going in to a specialty clinic. So that's Goodland has been the same way, where they bring in all their specialists, a day or two a month. So that's exactly what we are looking to do.
So this would have to go through San Luis Valley Health, then we would probably have to share that. We would have to share this information with them to get you, involved and be able to provide those services here, because they do have general surgeons who provide the services now. I believe, and my team can correct me if I'm wrong, and I'm speaking specific to the San Luis Valley, I believe that they're scheduling colonoscopies out at least a month or so. We're still playing catch up with regards to COVID, probably like everybody else is.
Yeah.
And then we do have some patients. We're fortunate here within the San Luis Valley and the hospital, they do have a charity care program or a sliding fee program where they can receive services at a discounted rate. But then there are some people who don't qualify for those services because of their income. They make too much to qualify, but not enough to really pay for insurance out of pocket. So that's that group of people that we have difficulty finding resources for colonoscopies. So if this could be set up here in the San Luis Valley with SLV Health, that would be great. Thank you.
Sure. Yeah, I think, in those sites where a subspecialty clinic is already established, that makes the transition very smooth. And I think that's been the case with Goodland Regional and Lincoln Community. They have physicians that are going out there. They've never had a gastroenterologist there. And so we've had to kind of develop that program over the past year since I've been there. But then there are other hospitals that have several subspecialists coming out, some even from Denver, and they already have those transportation logistics worked out. And it's so easy to piggyback on that and add what is a fairly rare offering from these rural community hospitals in terms of GI subspecialty clinic. I know they can have a general surgeon that does colonoscopies, et cetera, but there are not many that can offer a subspecialty GI clinic. And I don't know that they realize the need until they've seen it happen. And now I've got, Alex has gone from 1 day to 2 days a month and probably room for more. Lincoln Community, as we've been actively discussing how to get more time there. So the need is there for sure, even just with clinic visits for chronic GI illness care. I mean, the need is huge.
So Marisa, maybe that's something we could talk offline and maybe visit with SLV Health to see how they could, it's an option that they have.
Yeah, definitely. Not just, I know the colonoscopies, but things like you mentioned, are out, and so it'd be nice to get people in quicker and have more options as far as, like you mentioned, discussing those GI visits and stuff that we actually send for specialty care, not just necessarily the colonoscopies. And so I think that it would definitely be a huge help. I'm not sure what that process looks like. As Laura mentioned, it's another entity, and they do have different specialties coming down, 1 time, 2 times a month, or whatever that looks like. But it would be ideal to work on something to get that set up, because we have a centralized referral team that works specifically on specialty referrals, and I GI endo is definitely a huge one, and to be able to, like I mentioned in chat, to get people in more timely would be ideal.
Yeah, I think once these opportunities get up to leadership from the various hospitals, it's easy conversations for us. I mean, we if they're interested, we set up a time and talk to them. As we've done this at our respective sites, we've gotten more insight into financially, how does this affect the hospitals? One of the most important things to us as we started doing this, and as we've been at our own sites even before formally establishing GI Community Solutions, was we want to do this for the right reasons. We want it to be beneficial for all parties involved. And almost as importantly, this cannot be a crippling financial decision for the hospitals. Like, they have to make out, well, not just serving their communities, but it can't come at a financial sacrifice. And we've seen in the models that we're currently practicing in, this is easily break even and pretty easily financially beneficial for the local community hospitals too. So again, it's just a model where every party involved is winning in this. And I think that the more that we can get that out there and have these discussions, we're going to be limited by the number of physicians and so forth and the amount of time that we have, but certainly not by the need.
And we got a comment from Anna, who's based in La Junta, also associated with Valleywide, and she said the same goes for our Arkansas Valley. In the Arkansas Valley, our hospital here in La Junta has a specialty clinic at the Arkansas Valley Regional Medical Center. We do have a GI here, but he schedules out up to 3 months sometimes. And then I know we have a few people on from the Western Slope. It's all I know. You all have been focusing primarily on the Eastern Plains so far. Has there been any discussions about eventually perhaps expanding to the Western Slope side of the state as well?
Yeah, I think so. We're not, limited to any, we're not limiting the scope of this to any certain region. The places that are closest to Denver are just easiest. If you don't have to fly, it's way easier. And it's also it's easier on our end to get the buy-in from a doc in Denver if you can say you're just leaving in the morning and you're home that night. I think the Western Slope is a little bit more challenging in that way, but it's certainly, doable. We've talked about maybe, having a model where somebody goes out for 2 days, does office visits 1 day, procedures the next day, something like that, just so it's a little bit more efficient. But yeah, absolutely.
Yeah, one of the big barriers as we were literally looking at hospitals on a map of Colorado and Kansas and trying to, figure out the logistics of this early on. And I've done a lot of cold calling, as Alex has, and emailing and so forth, many of which go with no response at all. And but those logistical challenges, I think we're already figuring out with only our respective sites. And I think that we've got some relationships with some charter aviation companies, et cetera, that I think are going to be a huge strength going forward, and probably going to open up a lot of those sites that would have been previously considered either unreachable or difficult to reach with a single day of work. But we're working through all that, and I think it's going to get easier.
Cindy, not to put you on the spot, but since you're based at, Uncompahgre, and your patients often travel up to Grand Junction or over to Montrose or Olathe, for care, do you see a need for more GI capacity, or are there other specialty clinics that you've seen a similar model where other providers come out from Denver or another area for regular time periods? Cindy might be multitasking and not able to come off mute, but Cindy, if you want to add anything in the chat, that would be great.
Yeah, I will say, oh, go ahead. There she is. Yeah, Grand Junction and then Montrose for surgery. Yeah, there are a lot of hurdles and there are a lot of barriers to doing this in rural communities. There's going to be limitations of space. There's going to be limitations of staff and their availability. There's going to be limitations in terms of equipment to get it done. One of the big limitations is obviously just the gastroenterologist, the providers. And so I think we're able to solve that part of it. And I think that there are developing a lot of programs, either from Olympus or other equipment providers that are making this a little bit easier, that have programs to allow these rural community hospitals to provide this care, again, without going so far underwater financially that it's incomprehensible. So I think that this is only going to grow in terms of availability and need. So we're pretty excited about that.
I would just love to hear, are there any people out there who are already bringing out specialists from Denver, like possibly who have experience working with aviation, because that, I think that's, as we've alluded to, as Nada said, has kind of been one of the big barriers. So just have experience with that side of things. I'd love to hear what, how they've been working that with, maybe with other specialists, if not with GI.
I know SLB Health does bring out a cardiology group from Denver Aurora Cardiology. I want to say twice a month, once in La Jara and once in Del Norte. So they are flying Dr. Nawaz out, and I'm not sure what charter they use, but I know he does come at least twice a month to the Valley.
From Denver, or from the Denver area?
Yes.
Carla, we don't have anyone that flies out to Grand Junction, correct?
I know that St. Mary's has an outreach clinic for pediatrics. Dr. Sivak is the one that comes in.
Oh, that's right.
But that's pretty much it.
Yeah.
The question, the thing somebody mentioned about uninsured patients, that again, is we don't, because our model is just kind of we're there for the day, we get paid by the day. We don't have any issue with what insurance patients are on. I don't know. So it makes no difference to me. You know, that would be something we've never, I think, formally explored, but you know, we're happy to do procedures on any patients if it's something that the hospital felt like they had a grant or they wanted to do a program. You know, we're happy to provide that care, because again, it doesn't make a difference to us what reimbursement rates are. So that, I think, you know, could potentially be a differentiator from other, you know, if issues with like local GI doctors. And again, I mean, we're not trying to compete with local GI doctors, where most of the places we're talking about going to, there are no GI doctors. But just that issue of, you know, someone mentioned about discounts or uninsured patients. That's one of the nice things about our model, is that it doesn't matter to us what insurance patients have.
And while we personally have expressed concern to ensure that these hospitals don't lose money by having us out there to do what we do, neither of our hospitals has given us any impression that they care at all. They take so much pride in being able to offer this to their patients in their community that it's almost like an afterthought for them, and they know they're doing just fine. We've found through, again, getting access to financials, that it's pretty easy to break even with, you know, 3.5 procedures average per day that we're out there. But they don't seem as concerned about it. And again, we're not doing our own billing. We don't have any concern at all who you know, what's our portion of private payer versus Medicaid or Medicare, or uninsured or underinsured. We want this to benefit the communities. We have to establish some sort of per diem model, because again, we are trying to set up a program that offers the highest quality of gastroenterology care in the entire state of Colorado, going to a site completely separate one day a month and provide that care locally. So we have to keep this as something that we're able to recruit these physicians and get this done, but this is not an elevator that keeps going up and up. I mean, we need to establish these sites. We want to provide the care. The hospitals love it. Once you do that first day or two, I mean, the floodgates just open, and you really see what that completely unrecognized need was prior to that being established. Getting over that barrier is tough. We've had a lot of conversations with a lot of hospital leaderships, all of which have ended up going very, very well. But it's a big barrier for hospital leadership to see the benefit in this immediately, and it takes discussing. But I think that once you discuss it, it becomes pretty obvious.
And of course, usually hospitals have the most capacity to support specialty care like endoscopy. And Dr. Ende, I know you've been we're on the call last week where we were talking about links of care. And I know Raya from our Salud team is on, whose Salud has been able to do endoscopy at one of their primary care sites and set that up. So that definitely could be very challenging to have the right infrastructure to do out of a primary care clinic. But Raya, I don't know if you want to say anything about the success of what you all have set up at Salud for getting endoscopy available at primary care, which I know could be another avenue to explore for some clinic sites if the hospital's not on board.
Sure. So can you hear me okay?
Yes.
Okay. So we've been very fortunate with Dr. Elzinga, founding this program and getting some substantial donations to do the equipment, because really just founding the program for us, that's a major hurdle, being able to have the appropriate scopes, processor, scope reprocessing machine. All of that is a massive investment. And so we were able to get that up and running through some very generous donations. And then that being our first hurdle. And then of course, the second, which is kind of ongoing, and I think will be for all of us, is the staffing piece of it. Finding sedation nurses who are qualified and comfortable, finding pre-post nurses. And then, the endoscopy tech is kind of a tight market to find somebody who is willing to step into away from hospital care and do sort of primary care screenings. We set in some pretty rigid requirements initially in terms of patient screening. So ASA 1, ASA 2, patients who currently we are primarily serving patients who are uninsured because the billing piece of it is also complicated, shall we say. And so we really have been able to grant access to a patient population that had not been able to have access through our community healthcare system and through our local hospital. They've been a good partner for us over the years, but post-COVID, we all have that backlog of patients, and then navigating them through an increasingly complicated system. We just weren't able to get the capacity. So we, after pursuing many aspects, it's kind of one of those ones where it was a build your own. And we've only been doing scopes since early December. So, still getting our legs under us in the program, but so far it's been going exceptionally well.
Yeah, that's great. I mean, we're both aware of what Salute is doing. And again, our hope for this as we expand, as we get more physicians involved, as more physicians that we get involved see how much fulfillment we get from serving these communities. Our goal is not just to take care of rural communities, it's to bring this back home. I mean, both Alex and I have privately discussed our willingness to donate time. And when we talk about other barriers, other hurdles to getting that done in local Denver communities, whether it's Sunrise or Salute, or, there are a lot of people doing this great work. The other barriers of staff, of, this person doing that. I don't want to overcommit us, but we know all these people. I mean, we work with them every single day. We have a lot of contacts to not just have this as a vision, but make it real eventually as this program grows. I mean, as we build this out and we've got more physicians involved, I think that we will, as owners of this entity, have the power to say there is a lot of benefit to a physician doing this in these rural communities, and to even that out, you will owe a little bit of, you will be donating time on a certain frequency to try to help some of the local Denver communities. That's from the very beginning been one of the almost inevitable mandatory parts of participating in this program as a physician and provider, is that there will be some paying back to the communities. So.
Any other questions or comments from the group? Awesome. Do either of you have any questions or follow-up action items for us or the people on the call that we can think about offline and maybe reach out to you about? I know that it looks like there's a few connections that can be made, and we'll have both of your emails in the follow-up email. But is there anything else you'd like people to think on, or be open for opportunities or connections before we close out for the day?
You could start, Alex, and I'll tack on afterward.
Yeah, I think the lowest hanging fruit, for us is like I was asking about, the places that already are bringing out specialists from Denver. That makes it so much easier. So we would love to, we've reached out to a lot, but if there's more out there that are already transporting physicians from Denver, that just makes it so much easier, and is a good place for us, to start. Eventually we'd like to be able to, do our own transportation, maybe even, contract with an aviation company. But if places are already doing that, that makes it's a lot smoother, and it's just kind of an easy place for us to start. So I would, especially if would love to hear about, those places would be great.
Yeah, and every single potential site, potential community for this kind of program will have its own unique barriers and its own unique hurdles, but none of those are insurmountable. I mean, they're all, once you separate them out and you're addressing each piece by piece, it becomes a very realistic thing to establish in that community. I mean, we've already been discussing at length with the community in Eastern Colorado that has no endoscopy equipment. And so I know from being at Lincoln Community, this leasing program through Olympus, that these sites can get this and not have to pay the entire massive upfront cost upfront. And this is something that, again, through time, they'll be able to pay for without having to take a huge hit upfront. And so as we expand sites and as we do this and establish this subspecialty clinic at more and more sites, we're going to learn more about it. And that will, next corner we come around where we have an issue that we've actually already dealt with somewhere else, it will become easier and easier. And that includes the travel logistics and all that stuff. So again, there's no unique hurdle that wouldn't be something you can't overcome with some planning. So just brainstorming and discussing and maintaining those open lines of communication is the way that we want to start doing this, because there's a ton that we still have to learn about how things are done in these rural communities. We've been very successful at our 2 sites so far, but that's only 2 for 2. There are going to be other challenges, other places. But yeah, we look forward to it. We're really excited about it.
So for all of you that were based in primary care, but thinking there might be a need in the community, would definitely love for you to start reaching out to your local hospitals and starting those lines of communication. And please feel free to reach out to Dr. Ende and Dr. Shoemaker with any questions, and we'll be passing along their information.
Great. Thanks, everybody.
Yeah, thank you guys so much for taking the time. We really appreciate it.
Thank you.
Thank you.
And I know that Andy wasn't able to make it today, but I know that she has ideas where other meetings she can bring you all into. So we'll be in touch as well.
Yeah, for sure.
Awesome. Thank you.
Thanks
Thank
again,
you.
guys.